Hi, everyone. Hi, everyone. Welcome back. Happy New Year. Welcome to Cambia Grove. It's great to see you all. I see a lot of faces that I recognize, and I also see a lot of new faces in the crowd. For those of you who are new, my name is Maura Little. I am the Executive Director here at Cambia Grove. Cambia Grove is a healthcare innovation hub focused on bridging the gap between entrepreneurs and the traditional healthcare system made up of the 5 points, the 5 sectors: payer, provider, purchaser, patient, and policymaker. Simply put, what Cambia Grove does is we try to make innovating in healthcare easier, period. And so we do that with a number of different avenues, number of different ways, including bringing the community together for programs like this, the 5 points of healthcare, the overview panel. And I'll get more into the overview panel, but what I wanted to do is just take a little bit of time before we get started, give you a sneak peek about what Cambia Grove is going to be up to in 2019, and also talk a little bit about the power of connection, the power of community connection, specifically in advancing healthcare innovation. So a couple of years ago, I met an entrepreneur. His name is Rob Arnold. Rob Arnold, at that time, was an entrepreneur in residence at the University of Washington's Co-Motion Lab. And Rob and I got to talking and really about the Affordable Care Act, healthcare in general, what the state was doing specifically to implement the Affordable Care Act. And so I told him kind of that broad overview and gave him different specific examples about, hey, it's from fee-for-service to value-based care. Hey, it's mental and physical health integration. Oh, and the Healthcare Authority is looking at putting together these things called the Accountable Communities of Health. And Rob picked up on the Accountable Communities of Health and said, I wonder what that really looks like. So he went back a couple of weeks, did some research, came back to me and said, I think there's something there with these accountable communities of health. I think there might be a way for me to help, but I'm not quite sure. Maura, would you be willing to connect me with someone at the state to better understand what these things are really all about? So I said, yeah, let me think about who would be best. And I ended up calling my friend, Dr. Bob Crittenden, who at that time was, yes, Bob, I got your attention, was at that time was Governor Inslee's senior healthcare policy advisor. And Bob said, I think, let's have a conversation. Let's sit down and talk about the accountable communities of health, and let me bring my friend Dan Lessler, who is the chief medical officer at that time for the Healthcare Authority. So Dan and Bob, Rob, myself, and a couple other folks sat down in a room and started talking about what was going on with accountable communities of health and what they might need. After that meeting, Bob and Rob and Dan had multiple meetings after that and ended up connecting Rob with Accountable Communities of Health in Kitsap, which is the Olympic Accountable Community of Health. A couple months went by, I didn't really hear anything. Every once in a while, I'd get, a text or a call. Oh, I'm on a ferry boat. Hey, let's catch up soon. Fast forward to September of 2018, when Cambia Grove put together a new program called Success Stories from the Field. And during the Success Stories from the Field, we invited Rob to share his story about finding success, about connecting those dots and really listening to what was needed within those communities in Kitsap and forming the Health Commons Project. Now, the Health Commons Project, what it does is it takes an existing technology that I found up in Canada, overlays that with a bunch of different entities within Kitsap to find out how to better refer different people who needed services throughout the entire peninsula community. And it has found some incredible traction. It was able to reduce the need for people to literally pick up the phone, to literally, that was funny too. That was good. to literally pick up the phone, to cut back on those times for people who were getting referred to services, cut back on those wait times for those people, and get people really the help that they need from the KidSAP and the Olympic Accountable Community of Health as a whole. So that was one story about how connections here at home have translated into some tangible work to help serve people in healthcare and really in our community system. At that success stories from the field, I jotted down a couple of notes of what I heard Rob really saying. And here are 3 highlights of find the path of least resistance and take it. Their healthcare and innovation is hard. We all know that. That's why Cambia Grove exists, is to make it easier to innovate. But really, find the path of least resistance and take it. Listen, first, second, and third, then act. What Rob did was really interesting. He didn't come to the Accountable Communities of Health with a solution. He came to them and said, I think there might be something there, but tell me more. What's really going on? What do you really need? And was able to form the Health Commons project off of those learnings. And then last, leverage stakeholders to engage in solution development and to become your champion. This is really important, is that Rob was able to bring together kind of a parade with him of folks, of stakeholders who were rooting for him because they all believed in this project to get people the help that they need. Specifically, what Rob said is that it's a marathon, not a sprint. If you want to jump straight to the finish line, you are in the wrong industry, and we all know that. It's tough innovating in healthcare. So fast forward 2019, how is Cambia Grove working to help make it easier to innovate in healthcare? We've got a number of programs listed up here that we will be taking on throughout the year, including today's program with the 5 points of healthcare, which is the overview event. This is one of my favorite programs that we do by far. It is fascinating and wonderful, and I can't thank the panelists enough for joining us today. We're also doing a healthcare innovation landscape report. We're actually going to be launching one in Utah next week, which will be really exciting to see what's going on in Utah in healthcare innovation. And of course, we've got the startup census moving forward, which the startup census in Washington State has almost 500 startup companies that are listed on that census. So please feel free to take a look at the census, put your name on the census if your company's not on there already, and populate it that way. But I want to take a moment and talk about 3 specific programs that we are working on in 2019. The first is the Data Resource Directory. Now, this time last year, I came up and I spoke about how Cambia Grove is putting together a new series called the Solution Series. It's where we look at bringing together the community at large and talking about barriers in healthcare by selecting a specific topic. So we convene the community around that specific topic. We identify both barriers and opportunities to help in that topic to break down those barriers. And then we catalyze solutions based off of what the community pulls together. Our first topic was data. And for those who know me well, came up afterwards and said, wow, okay, more data. All right, what's next, world peace? And I was like, well, maybe. But no, we won't do that just yet. So the first one was data. After 74 stakeholder interviews and a number of different community engagement efforts, we came up with a list of about 19 projects that we're hoping to tackle over the course of multiple years here at the Cambia Grove. The first project is the Data Resource Directory. And this was a direct result of us having a conversation with an entrepreneur saying, hey, if only I had access to this data resource, I could really make progress in healthcare innovation. And then 2 interviews later, we would hear something from someone who had a data resource saying, gosh, I've got this data resource. I wish that entrepreneurs would use this more. And so what we pulled together is literally a list of data resources that are available to changemakers to utilize. We currently have 20 resources listed out on the data resource directory, and it lives on our website. So please take a look, peruse the data resource directory. Let us know if there are other resources that you use or that you know your friends are using that would be good to feature on the directory, and give us feedback. Julie Anderson here at Cambia Grove will be at this table over here after the event today to talk about the data resource directory and to get your feedback. So please join Julie over there if you have comments or feedback. Second thing that I want to mention is the Cambia Grove Fellowship Program. Now, one other thing that we heard within these 74 stakeholder interviews was that it would be really great if entrepreneurs could get real life experience getting their hands on some data. What are the challenges when inputting data? What are the challenges for these large entities when utilizing the data? And so what we are excited to announce is that Fred Hutchinson Cancer Research Center has decided to partner with us to make that a reality, to partner with us on the Cambia Grove Fellowship Program. More details will be coming out this spring about the Cambia Grove Fellowship Program, but what that really means is that a select number of entrepreneurs will have the opportunity to work side by side with researchers at Fred Hutch to get their hands on data and understand those big challenges. So big thank you to Fred Hutch for partnering with us, and we are very much looking forward to launching the fellowship program this spring. Lastly, I want to talk a little bit about trails, and then we'll get on to the show. So trails competition, the first one launched last year, where we partnered with UW Medicine's Primary Care Innovation Lab. The thing about trails is that the winner didn't get money. The winner, there's a lot of different competitions out there that come with a prize or come with a number of different things. What the winner got with Trails was real-world application and testing through the Primary Care Innovation Lab at UW Medicine. And I'm really pleased to announce or to share again that Light Sprite here, Swati, who's sitting right here, was our winner of Trails last year after making it through an entire competition process. We got applications from 5 different countries, 6 different states, and an entrepreneur right here in the Pacific Northwest won. So again, congratulations, Swati. This year for Trails, we're going to be doing 2 competitions. The first one will focus on children's hospitals up and down the I-5 corridor from California, Oregon, and Washington State. That will launch in the spring of 2019. The second one will be focused on the primary care innovation lab again with primary care setting. That's through the WWAMI region, which is the Washington, Wyoming, Alaska, Montana, Idaho region that UW Medicine serves. So keep watch for those 2 announcements coming up with Trails, and we look forward to having that competition again in 2019. All right, enough of me. It's fantastic to see everyone here, and we are really looking forward to kicking off our 5 Points of Healthcare program series today with a fantastic panel. So I'm going to give a little update on what's going on today and give you some context and everything, but as I do that, let's go ahead and have our 5 points come up and get seated. So join me in welcoming 5 Points. All right, so last year, the 5 Points of Healthcare conference was a conference that we created. The 5 Points is a structure, framework that we created. There we go, perfect, that's okay. Oh, that was great. So, 5 Points of Healthcare. You guys ready? All right, so 5 Points of Healthcare, it is a framework that we created to help simplify and break down what the healthcare system really is. We broke it into 5 distinct sectors. Again, payer, provider, purchaser, patient, and policymaker. Last year, we really asked 2 questions. It was, how is the healthcare system designed to work? And then how does the system actually work? What we did, if you all were here last year, is we had a graphic recording artist literally make a drawing of what the conversation looked like, and it hangs on our wall over here on the Cambia Grove. What we found literally on the drawing was that there's a lot of opportunity to innovate in healthcare. All of that white space was supposed to be the connection points within the 5 points. And really what we learned was that they don't always connect. And that's a great opportunity for us as a community to come together to connect the dots. This year, we've got a similar construct in that we're bringing together all 5 of the 5 points for an overview event today. And then each month, starting in February, we will do a deep dive into a specific sector. So February will be the month of the patient. March will be the month of the payer. I think, I'm looking at Julie, I think it's the month of the payer, and so on and so forth. So check out all of the different 5 points calendar events that we've got going on within Cambia Grove. We would love to see you back here for each of these events. This year, we are going to be focused especially on how's the system designed and how's it actually work. We're also going to take a look back at what innovations have made a difference for each of these points, and then what trends should we be expecting moving forward. So with that, thank you all again for coming, and please join me in welcoming our 5 points panel.
Great, thank you very much. So my name is John R. Graham, and I'm here to represent the United States federal government. I see the first question here is how our sector was designed to work and how it actually works. It's all going fine. I think, are we done? Or I could ask you to call your families and say you won't be home tonight, because we got a lot of explaining to do, right? So my office is here in Seattle. I'm the regional director for the United States Department of Health and Human Services. My territory overlaps a lot of Cambia Grove's territory. My territory is the 4 states of Alaska, Idaho, Oregon, and Washington, and the tribes in those states. My job basically is simply to represent Secretary Alex Azar in this region. So it's not as bad as it sounds. The U.S. Department of Health and Human Services is largely up and running. We are not subject to shutdown because much of our operations are what is called mandatory appropriations. So Medicare and Medicaid, which are the big kahunas, they don't go through that normal appropriations process, which so often fails in Congress. So they're up and running. Most of the discretionary parts of our department are up and running because there are 12 appropriations bills, and most of us are funded by the bills that got through already. So most of us are funded like Substance Abuse Mental Health Services Administration, Agency for Children and Families. Those programs are funded through September 30th, so they got done in a sort of a quasi-regular order. FDA, if you have business in front of the FDA, if it's user fee funded, like drugs and devices, that's up and running. Food imports, they're being stretched right now because they're subject to the shutdown. And there's some other parts of our department that are involved in Superfund, stuff like that. But largely, the U.S. Department of Health and Human Services is up and running. How are we funded? Well, thank you. Your taxes fund us, of course, subject to appropriations by Congress in that broken process that we experience year after year. Although this shutdown hasn't really affected the U.S. Department of Health and Human Services largely, it is the longest shutdown in the history of the federal government. But the fact of Congress not hitting its marks that are imposed on itself by statute is not remarkable at all. In the 30-plus years of the current budget kind of statute that governs Congress, they miss those marks all the time. So we always come up against the September 30 deadline with some grimacing and winking and trying to figure out what will come next. The other way, of course, we're funded is through not just your general income taxes, but your payroll taxes. The biggest program we have is, of course, Medicare. There's different parts of Medicare, and the payroll tax that gets deducted from your paycheck goes into the hospital insurance trust fund, When you retire and turn 65, you start paying the Part B premium, which goes to pay for the doctors. And there's also Part D, which is also a premium you pay after you've retired, which pays for your prescription drugs. Now, the interesting thing there that most people don't realize is that Part B and Part D premiums only pay for a small share. About a quarter of the Part B costs are paid for by the premiums. The rest is paid for by, us and our children and grandchildren, and Part D as well. Now, the Hospital Insurance Trust Fund, of course, again, although I say, hey, don't worry about the shutdown, it's mandatory, it's coming off your payroll. There is every year a Medicare and Social Security trustees report, which shows how that trust fund is being managed. Because it's pay as you go, your payroll taxes don't pay for your hospital benefit when you turn 65. It pays for people who are already over 65 and getting hospital benefits. So by 2026, that's according to last year's report, this year's report will have a new date, and it'll be forthcoming in a few weeks or months. And of course, two of our high-level officers are on that. The administrator of CMS and the secretary of HHS are both trustees of those trust funds. It was 2026 was the year that the Hospital Insurance Fund would go underwater, and we'd have to figure out some other way to pay the Medicare hospital bills. So although it's not discretionary appropriations, it's a looming problem. I would also, I guess I'm down to 2 minutes. Again, I'm not going to predict. Don't bother asking me when the shutdown is going to, I'm not going to answer that question. I have no idea. But yeah, I mean, obviously the federal government is responsible for a lot of this, so I'm looking forward to the rest of the conversation and hopefully not avoiding blame, but looking for solutions. Thank you.
We have a few minutes for questions for John. And raise your hand, and then we'll get a mic to you. If not, I'll ask a question. Questions? Somebody up here? So I'll ask a question. Oh, there we go. Somebody up front.
I would like to know if you are flooded with ideas and the bottleneck is actually giving audience to these ideas, or if it's kind of crickets over there.
Oh, we're flooded with ideas, and we process them in many ways. Out in the regions, part of my job is to get feedback. One reason I come to Cambia Grove and meet with you folks is you are the entrepreneurs largely, and I learn from you folks what's out there on the market and what you're thinking of, what you're doing, so I feed that back. Whenever there's a rule, in terms of our process, it's called a notice of proposed rulemaking, and there's always a comment period so people can throw comments in, and they are all reviewed. I mean, some rules get lots of comments, and everyone should be enthusiastic about putting comments forward and not just let the comment period be dominated by people inside the Beltway. We also put out, again, there's going to be a point in the program where we talk about acronyms. One of our acronyms is RFI, Request for Information, and we quite often put out requests for information, and we take those very seriously. I know some of the folks in this community are aware of the deputy secretaries. Maura, you probably remember what the acronym stands for better than I do. The Innovation and Summit. Yeah, so we want to hear from, and they've had one request for information that closed a few weeks ago, and they're going to have a meeting of the private sector people who have joined that summit, and then they'll have another request for information. So yeah, we're deluged with and we're happy to be deluged with ideas. That's what we're here for. So it does take time to get through them and to obviously reconcile them. The more ideas that people throw at you, the more conflict there is among the ideas. So we have to reconcile them.
We have one more question here. Hi, thank you, John, for those comments and being here. My name is Don Downing. I'm the endowed chair of the Institute for Innovative Pharmacy Practice at the University of Washington. And I've spent half of my career opening up tribal healthcare clinics throughout the Northwest and all the early Self-Determination Act clinics I helped open up. So a whole time I worked with tribal health, and all the time as a pharmacist, CMS has never recognized pharmacists as providers. So we've never been able to be paid a penny for any of the services we provide. And yet in the state of Washington, the governor signed a bill that I helped write 3 years ago, and a lot of innovation is occurring as clinics use pharmacists part of their medical team to help the chronically ill people. But the most chronically ill people are the elders on CMS, and I don't know if you have any insight why CMS has failed to recognize the entire profession as a profession. I'd appreciate your insight.
Well, thank you very much. And I was hoping I would not have to talk about tribal, but that's okay, because one of our operating divisions is the Indian Health Service. I didn't mention that. And within our region, we have about 900 employees, of which 700 are the Indian Health Service, because it is a health system that we operate, a closed system we operate. And you introduced terms like that are, we don't want to delve into it with this audience, but the self-governing compacts, or the different ways that clinics are managed. But Indian Health Service is subject to the shutdown, so that's very unfortunate for those folks on the reservations, because those clinics are now struggling. I would refer you to, we just put out a report in November, actually came out of the three departments, Health and Human Services, Department of Labor, and Treasury, called Choice and Competition in Healthcare, where we discuss scope of practice and stuff like that. And I can't give you any insight or any prospects, but I'm glad you're bringing it up, and keep bringing it up. Thank you.
Hi, everyone. So yes, I represent the payer side, and I like to think we've gone through the most metamorphosis over the continuum. Others may disagree. When you think about it and you think about the payer side, it all really started, and even where Regents, and you look back at Regents' history, it was over 100 years ago, where it was really a bunch of loggers and their family, and they were pooling dollars to actually fund general healthcare expenses. So thinking about all of this, it's that continuum that's how it really started. It was purely a funding mechanism. And so that was the genesis of insurance, and then how you started to get a lot of changes across the industry around how did you look at risk? How did you start to form these populations and these pools, and thinking about primarily funding? Then it started to grow where you added, well, what are the benefit provisions? Because if you're going to form a pool and you're going to create coverage, how are you going to define what is and is not covered? How are you then going to say, well, what are you going to do to help manage that population, their overall costs? So you have from claims payment, you have the customer service who answer questions, you have network who is setting up now a network configuration. You have providers who are helping to establish policies and what's evidence-based medicine. But it was many, many changes across like an entire sector. And so I like to also say that we like to call ourselves healthcare, and I think many of us view ourselves as we're part of that healthcare continuum. But if you look at how we've moved over these years, we went from probably something that might have been more deemed healthcare to we kind of became sick care. And so, that was a period of time where the system really was all generated around, well, if you're not sick, you're not really in the system. And then that's when wellness programs, that's when we started to look at how do we better and manage condition management. So when you think of like the payer, we're no longer just thinking about funding. We're thinking about, if I'm going to have this member for a period of time, how do I keep them healthy? How do I look at from this paradigm of what the purchasers, and you'll hear from the purchaser next, what is their expectation? They come to us to help manage a program. That's not their core competency, and they don't want to be in the healthcare business, but it's a requirement. And so our role is to make sure we're developing programs. We can keep their families healthy. We can create that environment for their employees where they have someone to call to. We're trying to break down all the barriers. We're trying to eliminate noise and really move from truly becoming not just healthcare, but becoming almost these navigators in this health support structure to employees, to the members. And trying to break down, just as we're not to really talk, we were asked not to talk in all our acronyms, but all of you are in the healthcare industry, and when you have an event, most of you are probably still paralyzed. You know, you don't know what's next. And that's really where our role is radically shifting. So, and we connect to providers differently than once did. Before it was really, how are we contracted? You know, how are we going to just pay you, to now, how do we work together? So many things are changing. And, you know, in the next, you'll hear from Marion talk about the purchaser, and their expectations of us are radically shifting. And it changes every single year with what's needed and what we have to deliver from a payer perspective. And so it's really not payer anymore. It's how are we helping to manage the health of a population.
Just because it's an insurance company. Now, if you're a pharmaceutical company here, yeah, then you don't have to. But for insurers, of course. Any questions? In the back.
Hello. It's a nice image to think about the shift coming back from talking about sick care, now coming back to talking about healthcare. And I think maybe the words that we put to it now from that shift back is talking about wellness programs, which I think you touched on. So if your main focus now is thinking more about navigating wellness programs and investing in those payers and patients and their long-term health, what are some like standout wellness programs that you've seen, or what are you doing specifically in that realm?
So a couple things. One, first of all, it's like, while we're the payer, you know, it's yes, we have insured plans, but a lot of the actual companies who work with us are self-funded as well. So they define sometimes what they pay for or not. So that's one, you know, caveat sort of as we think about wellness. You know, everything from wellness is, how do you actually engage with that member? And so what creates those conduits? So a lot of it tends to be, how is it from more coaching? It's earlier identification. We tend to see it more around weight loss, where you can really create engagement. But it's also looking at our role differently. When is that member really willing to engage? What is utilizing like motivational interviewing? So it's like, if you were to say to me, you need to lose 10 pounds, if there's nothing motivating me, I'm not going to lose 10 pounds. But it's like, how do you find those things that create that motivation? And that's really, when you think about all wellness programs they're looking to do. The other thing I'd say is, we no longer go it alone. So at one point in time, it was, well, we're the payer, or we're the wellness, or we're just going to do it. We have more and more partnerships with providers. And so, you know, whether you want to call them accountable care, you know, it's looking at everything differently, but it's really partnering with providers and saying, how are we going to handle those members? Who has that better relationship? How are we going to connect them? Because oftentimes, you know, while we think of wellness meaning, how do I just keep someone healthy? A lot of times wellness is now, how do I help them live with a condition, a chronic condition that they will have for the rest of their life, and to give them the best life possible.
Hi, my name is Wei. So my question is, piggybacking off of the previous question, is when we're talking about wellness, how do we move that upstream to promoting
Yeah, so first I'll say we don't have an answer to that. And I think, you know, as everyone knows, social determinants of health. So when you look at where the various different, you know, the economies, the socioeconomic factors. There's many different items that are barriers for that. We are looking at, from how we have preventive medicine to how we're looking to try to engage. But I would view it as that area is not just on the payer. I mean, that's something that goes across all of us, from policy to what's happening at community to what's happening in our schools, and how do we support differently. I'm going to do a little plug. One of the things, and I think about kids, if all of you could help support changing the smoking age to age 21, that's a bill right now. But I look at that as these are all things that are interconnected, and how do we look at differently about what our role is. And it may not just be from a payer side. It could be from how are we helping from a policy side. Thing I will say is we have actuaries in the audience. They're probably thrilled that you say it's the actuaries who own that.
Yes, we purchase on behalf of about 2.2 million Washingtonians, and we cover about 1 out of every 3 Washingtonians that's not covered under the Medicare program. And the 2 main programs we have are our Medicaid program that we call Apple Health. So Apple Health is an income-based program. And so those who have a certain income level are able to, an asset level, are able to qualify for the Apple Health program. Additionally, we support the benefit program for public employees, which includes state agencies, higher education, some political subdivisions like libraries, other municipalities, as well as beginning in January of this coming year of 2020, we will be covering also the school employees. And as a purchaser through Medicaid, that's a partnership with the federal government. So the federal government pays about half of the cost, and the state picks up the other half of the cost. We in the state of Washington procured those benefits primarily through managed care organizations, and it's a very defined benefit package. So what a purchaser does is decide what are the benefits we want to buy within the context of federal and state law. As the employer purchaser, and so that is whether it's the state of Washington or Boeing or other employers, they have other decisions to make. So they are trying to recruit and retain a workforce by having competitive salaries and benefits. When they set up their benefit structure, they're looking for first defining who is eligible for those benefits based upon their actual work hours or their anticipated work hours. So I think it is an unrecognized piece of the industry around how important it is to establish who is eligible for benefits on the part of the employee. The Affordable Care Act set some boundaries for us around that, but that is also something that is left up to the employers to decide. Once they've decided that the employee is going to have benefits, then they also decide which of their dependents will also have benefits and how they're going to define that, and then what the premium share is. Oh, 2 minutes left. My goodness, I better hurry up. Gracious. Okay, well, you get the short version now. So we've decided who's eligible. We've decided what the premium is. We've decided what the premium cost share is going to be. We define a benefit package, and then we go out and we partner with plans and others to make that available to our employees. And what they do essentially is to contract with the providers and set up contractual arrangements. They also set up a contractual arrangement through a certificate of coverage which defines those benefits between the plan and that employee. And then finally, we also do other programs, including wellness programs, because we are also really wanting to focus on how do we make sure that employees, their dependents, as well as our retirees, which is another population that we serve who become duly eligible for Medicare and our benefits, they have the best benefits possible.
Good job. We have some questions. I'll ask a question then. From a purchaser's point of view, how come purchasers have not banded together to put more pressure on providers and payers to
there are several examples of how employers have banded together. There are in Washington states and other states that there are purchaser coalitions. I think one of the issues that you've referred to previously is the fact that the duration of that coverage is going to be the duration of the employment and then COBRA coverage. I think one of the other sort of dynamics that needs to be considered is for across purchasers, they will have different priorities in terms of their employee benefits and how they want to best position their benefits respective to their unique employee situation. So people who are employing those who are out in the field may have different benefits than, say, Microsoft, that is typically employing only office workers. So there's a large discrepancy. I think the other discrepancy that's pretty significant is across the plans with whom the employers have contracted, as well as within Medicare and the Medicaid program, there's a different reimbursement amount that's provided to the providers. And so that sort of becomes, those collaborations, they become part of that whole mix of what's the payment system that's also underpinning this industry.
Other questions from the audience? Up in the back we have one.
Hi. So just essentially to rephrase what you said earlier, right now, you know, we're a fee-for-service type healthcare system. And so the doctors have a lot of influence in, you know, putting out services. But at what point are the payers and purchasers, are you guys going to nudge this type of format to, I see a lot of, you know, behavioral health and wellness type people out there. Those entrepreneurs and innovators are there. How do you start nudging it in that direction so that that whole healthcare cost is reduced?
Right. That's a great question, because how do we really identify and start making sure that we're getting upstream to those needed services that are so much more expensive downstream? And there are several initiatives in place that we're working towards that. A couple initiatives that I'll mention, I would say that the state's investment in accountable communities of health across the state are one of those ways where we're trying to invest in communities to identify and to provide those early investments in terms of behavioral health, the opioid crisis, prevention, other types of services. The second example I would give is how we've moved towards more of a value-based purchasing. And so we do have contracts now within the state where we have partnered with more of the provider community, of course, working with our payer partners as well, to be able to start talking about how do we manage trend, and at the same time that we're managing the trend, the cost trend, how are we making sure that there is going to be the same quality? I've been in the industry long enough that I was here in the early 90s where the movie As Good As You Get with Helen Hunt and Jack Nicholson, and she talks about how, you know, all of this is, how cruel the health plans are to be imposing these rules on us, and really the demise of that sort of innovation that we were trying for in the early 90s. So we're continuing that work, and we don't have any more time.
So normally, and I'm going to.
Oh, this is on? All right. As you all can see, we have an empty chair. And unfortunately, our provider who was planning on joining us got caught up. But we do have another provider who is going to fill in last minute. Her name is Dr. Blair Washington. Dr. Washington, come on up. Thank you. As you can see, she's just coming up on the fly. Hopefully, Neil, you can give her some prompt questions when she does her overview to help that conversation out. Thank you for doing this.
All I can say is, and well, actually, let's let's go straight to you. See, now you're here.
Okay.
And the good news is that we found you because Bob didn't know he was about to get called up. Not me if you had not shown up. So tell us who you are and what you do.
So my name is Blair Washington, and clinically I do something called pelvic floor reconstructive surgery. I'm a urogynecologist and practiced until very recently at Virginia Mason here, so a big multi-specialty physician group here in Seattle. And so I'm very boots on the ground. Before I went to medical school, I got my master's in health administration, both medical school and my master's here at the University of Washington. So I have a long-standing interest in understanding how we provide healthcare to a broader community. And so I'm super excited to be here because I think technology is what's going to take us there right in this era. Let's see. I'm going to look at the point. Oh, okay.
If you were going to describe how does a healthcare system work,
yeah,
and you were in front of a group of people and had to describe it, how would you do that?
yeah. And I guess obviously my perspective is from the provider perspective, and what I see are a lot of inefficiencies and opportunities to improve. What I can tell you, I'm going to actually take a couple steps back because, I think the first thing that I'd like to define as a provider, I represent a physician provider. But as we have all heard, there are many different ways that providers are being described here. So sometimes they're physicians, sometimes they're other medical professionals like nurses and nurse practitioners and pharmacists and other people contributing to the healthcare delivery to the patient. Hospitals are also called providers in broad categories, health systems. And so when I say provider, what I mean is doctor or provider of medical care to the patient, direct provision of medical care to the patient. And how do I see it from my perspective? Like I said, I think there are a lot of inefficiencies and opportunities for improvement. What I can tell you from the boots on the ground is that there are a lot of providers that are very committed to delivering high quality evidence-based care to their patients. And we get hung up in from my own perspective again, the operational challenges of how that happens. I am a strong proponent, so some direct examples. I love the electronic health record. I can see how it can be leveraged for things like research and both population research and also academic research. But it is a huge cumbersome element to the patient-physician experience that I think can be improved upon. When in my practice, I do a lot of, I see a lot of second and third referrals for pelvic floor complications. All of those referrals are coming into my office in fax. And we know that technologically there are opportunities to improve upon that. I had a person in my office who is completely devoted to interacting with other hospitals, other physician practices, and having their records faxed to me. And so there are so many inefficiencies and opportunities to improve upon, and that's just in terms of the direct patient delivery, not all of the other operational issues that we're talking about today.
Yeah, so I think healthcare actually keeps the fax industry in business.
Totally.
People use it.
I said fax and pager, and people were like, what in the world? These things still exist?
So two questions just in more of education for the group. A lot of people, you're hearing people talk about accountable care organizations and value-based care.
Mm-hmm.
What does that actually mean? Because I think there's an opportunity in those terms for entrepreneurs. But what do they actually mean when you hear those?
What I think about is, I think the healthcare system under Obamacare, I shouldn't say under Obamacare, but as a consequence, we're moving very quickly from a fee-for-service system to a pay-for-performance system, where we're looking at how you create and understand what quality is in different specialties and deliver on that quality. And so that's how I think about it. I think about that within my practice. I worked on the national level with in my specialty, defining what quality outcomes were for different conditions, and then thinking about how we operationalize that for delivery in different situations.
So, questions from the audience? Right there.
Hi, I'm curious what tools you think are needed to help define those outcomes and measure value-based care. What's missing right now, and what would help make that more accessible?
The immediate thing that comes to mind, and I probably will walk out of here and think, oh, I should have said this and this and this and this, because there are a million different things. Yeah, exactly. But what I would immediately say is, for me, what I think my immediate goal is to really understand how to define quality. Because before we can start operationalizing on it, we need to have metrics that are definable, that people can actually report on. And we need to have easy ways to report. And so, this is the example that I always give, and forgive me if I'm talking too long, but I do a lot of surgery around the bladder. And inherent in that is, bladder injury is an inherent potential complication of those surgeries. And but if we're looking at coding data to report on outcomes, there's no coding data that we can bill for a cystoscopy, which is a procedure that can be performed at the time of the surgery to confirm that confirm the bladder integrity. And everyone should do that. So we said, as part of one of our quality metrics, everyone should do a cystoscopy at the time of a surgery to confirm that there was no bladder injury. But within our coding systems, there aren't ways to measure that. And so unless we're going to have manual entering of all of that data, we don't have, unless we develop artificial intelligence that can go through and scan the record and say that that cystoscopy was done based on a typed operative report, those codes don't exist for us to be able to report on things like that specifically, because they're bundled into the bigger code of the surgery, for example. I don't know if that makes sense, but.
Another question? Any other questions? Come on, she prepped for this. Put her on the spot. There we go.
Looking at a coworker because we were just on a call where this came up. The quality measures for specialty care, I think they're really, for primary care, are pretty robust. Well, as much as they can be, at least they've been focused on, for the last 10 years, and there's HEDIS and there's this. But for specialty care, it sounded like you worked within your professional organization to come up with some quality measures, but they're not accessible, I think, to the industry. Like, do you just have any thoughts on how to make those more accessible to payers, to government agencies?
Well, I know that the quality metrics that we developed are on the CMS website, because that's who we were creating them for. But it is true, these things need to be more broadly disseminated. And in many, like for example, even at Virginia Mason, my quality was reported under the primary care programs, as opposed to so it's really just individual practices that would be reporting on those metrics, which also decreases the utilization in subspecialty practices, because it's just not how things are being reported right now. But like I said, they exist, and these metrics in particular are on the CMS website. Yeah.
So we'll have to hold off, but this creates a nice little transition. Thank you. She deserves lots of applause. She really have no idea. Thank you very much. So one of the interesting things about what we're talking about data and talking about value and quality, and this is going to lead over to talking about the consumer, is it's great to have all that information, but for a consumer to make decisions, to actually make a value decision, you need to know both quality and price. And there are innovations out in the market, whether it's Vitals or whether it's HealthSpark. I'm pointing at different vendors out there. We're at an infancy in that. And so what I'm bringing this up for is to say this is leading us to what is the role of the consumer or the patient. And so, and what's our element of what responsibility do we have? And how can we make a difference in that? So I'd like to introduce, and I think I'm going to get it right, Aaron Chizewski, correct?
You win. Hey.
Thank you.
Thank you, everyone. It's great to be here, and I want to thank Maura and Cambia Grove for inviting me. I guess I'm here really to represent the patient perspective, and I'll start by just giving you a real quick background of what my particular insight into that is formed by, and that is I spent 15 years at the American Cancer Society. Most of that work was in advocacy, so when I think of patient advocacy, I realize that there's different ways that you can use that word. We activated patients, not only patients, but caregivers, survivors, and their family to affect policy change. And that was really an extraordinary experience in my life. But then I later spent 3 years at Leukemia Lymphoma Society working on patient services, although we, at that time, we were changing and introduced a new term for what we were doing, patient access. We felt it more appropriately described what we were interested in, and it was that patients have access not only to quality health care, but access to all the complexity of the various institutions that they depend on for the care that they need. And it's the most interesting thing, and that made me sit here listening to these presentations and to your questions and the discussion, and I was a little intimidated. I thought, this is so complex, and maybe I have the easy part in talking about the patient perspective, but then I realized really it may actually be the opposite, and that patients are people, and they're complex and come from all different situations and have various obstacles in their lives. So it leads me to now I am working for Food Lifeline, a food insecurity or hunger relief organization, and so now I work with clients, but clients that also can be patients as well. But in this case, people, again, but in very unstable situations. There's instability in their lives, and that makes them very desperate. And so, again, this perspective of a person dealing with something that is very complex, overwhelming, scary, facing institutions that, again, they will depend on for their survival is quite a profound thing. And I've often noted that now that I'm working in food insecurity, that the issue is actually as complex as cancer, which really surprised me. Cancer, which I believe to be the most profound problem of the human condition. But then I chuckled because I noticed that on the prompts, we were described terms and acronyms. And so in the same sort of bifurcated way where a patient can come in, a person can come in and be suddenly thrust into something that they feel like they're upside down and actually not even in a position to be ready to deal with what is happening to them. An acronym there would certainly be WTF, and I won't describe what that is. Okay. But at the very same time, I've worked with patients who could be sitting in this audience asking very demanding questions, and not only understanding the level of complexity that's introduced here, but being in a position to turn around and communicate that to their social network, which might be numbered in thousands of people, because a patient can be someone who's incredibly empowered and is really an influencer in the dynamic of the systems that are at play here. And that's a really powerful thing. And I think in the later discussion, we'll really get into sort of some of those dynamics and try to understand what's going on. But certainly the patient is the circle in the center of all of this that we're aiming to try to understand and to elevate and appreciate. And so I guess I'll be able to end there because I do want to leave time for questions, but actually get into the meat of the agenda. So thank you.
Who has some questions to look at this from a consumer or patient point of view? Dr. Crittenton.
Thank you, Nick. Everybody talks about being patient-centered as systems, and everybody says they want it. What is it perspective, and are we doing it?
That's a great question, and I'm sure that the expertise in this room will help tease that out. I think that's ultimately what we're trying to get at. And I do have some impressions, and I think that it maybe is helpful now that I'm in a different place in my previous capacities that I can either reflect back or maybe talk more freely about what that is. Because I think patient-centeredness can be something that is certainly a pursuit worth chasing, but I think that it requires a certain amount of discernment getting there, and that I do believe that not every patient is created equal or comes equally prepared to contribute in a way that is meaningful to an organization or institution that will be making big decisions about what to do with that influence or information. And so I think there actually requires more process, more rigor, more investment, more time to sort of cultivate what is what are the best aspects of that patient experience that the institution can react to effectuate change within how they deliver or show up in a patient's experience. I think there's also there's certainly a certain amount of just bringing everyone up to a certain basic standard of access that patients would have, transparency, authenticity, and genuineness in how we treat and incorporate and deal with patients. But again, at the same time, when we're going to start designing features of institutional work and responses based on patient feedback, I almost decided not to go here, but I wanted to use Steve Jobs as an example where he would famously not consult consumers in his decisions about what products to bring to the market. And I'm not suggesting that that's what happens here, but I think there is a part of a creative process where you have to sort of listen, interpret, but then make decisions free with your creative energy, and then really invest in that to bring out what is, in your view, most perfect. And then I would add, stick with that and until you can fully explore what that potential is. I feel like too many times organizations or institutions try things and they don't stick with them long enough to make the adjustments to make sure that they're working as they intended. And what that leaves is consumers, patients, or others who experience something different every time they come back. And just like anybody else in the world, we enjoy predictability, familiarity. So again, this is not giving you the answer to what is the best of patient-centered, but it is an aspiration that, again, I feel like we may not actually be able to totally control what that is, because a lot of what patients are now doing is through crowdsourcing and social media, social networks, going out on their own and creating their own social dynamics related to their disease or experience and introducing that. So it's one of these things where try to lead, try to do this right and be authentic, but at the same time know that you're not going to be able to control everything. You're going to have to react to the world that is rapidly changing around us. In other words, if you have kids, ask them what is working for them and then do that.
So we're going to follow the same order again. And this time we're going to begin to talk about innovation. What actually, now that we've got a little bit of an overview of what everybody does, now we're going to talk a little bit about what people have found to be innovative, the implications of that innovation, the holes, the gaps, the things that work, the things that have been plunged them into despair, whatever it be. And we'll start with John.
All right, thank you very much. And thank you, Dr. Washington. She blew up our plan to blame the doctors for everything. We conspired to do that. And anyway, so our specific question is two important innovations. So I'm going to talk about a policy innovation, which you all know about, but it's still resonating, is the Affordable Care Act of 2010. And that was a big, obviously a policy change, and it led to a lot of changes. Led to a lot more coverage, a lot more Medicaid coverage, and a lot more coverage in these new things called marketplaces. Now, you know, it got up and running in 2014, and what is not often discussed, but what we identified when we got in, and of course, to be blunt, we ran on it, was repealing and replacing Obamacare. And the reason was that it effectively split the individual insurance market. About 8 million or so folks nationwide got coverage heavily subsidized. And there were somewhat, the pain of the premium hikes that happened in Obamacare, they didn't notice because they got the tax credits. But a large number of people who were above the income level to get the subsidies for the premium tax credits, they drove, you know, to be blunt, the politics of repeal and replace. So we didn't repeal and replace it. So there you go. So you had, we're now in kind of Affordable Care Act next phase or whatever, and we've done a number of policy innovations around the Affordable Care Act, some of which are controversial, but they exist, so we might as well talk about them. One, of course, is the short-term limited duration health plans. Now, some of these things you won't see in Washington State because they're under control of insurance commissioners or state legislators. But short-term limited duration health insurance was effectively eliminated during the previous administration. But through rulemaking, we are now allowing short-term limited duration health plans for up to 36 months to be guaranteed renewable for up to 36 months. And we anticipate those premiums will be 50 to 80% lower than premiums on the exchange. So in states where insurance commissioners allow that market, you'll see grow up. We also have introduced so-called association health plans. So this will be important in the small business community, which struggle to get affordable health care. You know, around this town, you always hear about Boeing this, Boeing that, as a large employer which has innovated in health benefits. But small employers don't have a real opportunity to do that. So they can band together in associations, and that will just give more choice to small employers. You might remember in the Affordable Care Act, there was, oh gosh, what were they called? Co-ops, is that what they were called? They never, I mean, the small group part of the Affordable Care Act never really took off. So we're trying to resolve that. And a third innovation that we're doing through rulemaking around the Affordable Care Act is around health reimbursement accounts. There used to be, this is for very small folks in the individual insurance market who don't get subsidies through the tax credits, or if you're a very small employer, you might want to fund a health reimbursement account. The rule was, there was a contradiction between the Treasury Department rule and the Labor Department rule, so we've issued a new rule that the employer of a very small business can put money into a health reimbursement arrangement, an HRA, got to use the acronyms here, to an employee who can then take that to buy individual health insurance. So not a tax credit from the taxpayer, but a payment from the employer, the health reimbursement arrangement. The other change we're making in the Affordable Care Act is issuing waivers under Section 1332. You might hear people talk about 1332 waivers. And these are state innovation waivers that allow states to implement innovative ways to provide access to quality health care, at least as comprehensive and affordable as would be provided absent the waiver. And we're using, I guess the best way to simplify our approach to the Affordable Care Act at this point is, if you read the text of the Affordable Care Act, it says the Secretary shall, the Secretary will, the Secretary this, the Secretary that. We are using all of the Secretary's powers to give relief to people in the absence of repealing and replacing the Affordable Care Act. So that's the first innovation. The second one is, of course, health information technology. Specifically the uptake of electronic health records. And this was really given a boost, as you all know, by the American Recovery and Reinvestment Act, the Stimulus Act back in 2009, the first major, I think it may have been actually literally the first bill of the Obama administration, which funded billions of dollars. I've lost count. Was it 36 or so billions of dollars to induce providers to take up electronic health records? Yes, successful in that narrow measurement of uptake of electronic health records. However, obviously one problem was they never moved along the timeline of what we used to call meaningful use in a timely fashion, which meant interoperability. The 2016 21st Century Cures Act, massive bipartisan act, had in it, it identified the importance of easing regulatory and administrative burdens associated with use of electronic health records and health information technology, and giving more impetus to interoperability. It mandated us to put out a rule called the information blocking rule to stop this information blocking that we've seen providers engage in, not wanting to share information. And we are late in that rule. So that rule was supposed to be out, called the information blocking rule. And we're not there yet. We have delivered our draft of the rule to the Office of Management and Budget. And when it will actually come out, I can't say. But I'm looking forward to it, and you should be too. And the moral position here is, we don't make Safeway share its loyalty card data with Whole Foods, right? But the taxpayers paid for these electronic health records. It's you as taxpayers paid the providers to put these things in. The information in these electronic health records has to be shared because to some degree it's our property as taxpayers. So that's where we are in that. Thank you very much.
Do we have any questions? Oh, but we can applaud. Yes, we need applause. Oh, come on, do better than that. Oh, yes, so you can all ask questions if you want. So either the audience or the table, any questions for John with what he's talking about in terms of the innovation? Up.
Here's a mic coming to you.
What type of information are you trying to extract from the electronic health records? Are you looking for just anonymous data collecting stuff, or what are you?
No, we're looking. Well, there are a number of reasons, but the easiest way is to go back to Dr. Washington. Fax machines. Seema Verma, the administrator of the Centers for Medicare and Medicaid Services, wants doctors' offices to be fax-free by in short order. Her own story of dealing with her husband's care at University of Indiana is running around with CD-ROMs and stuff. We want patients to experience a seamless system of providers. That's really what we're trying to achieve. That's probably the major thing we're trying to achieve. There are also big data implications and stuff like that.
I mean, I strongly believe that, we as patients all own our health information, and currently it is housed with our providers and health systems, and I strongly believe, I would love to partner with you on this. I think there have been so many barriers to creating personalized health records that patients can own and transport to different providers as they feel are necessary. That would alleviate. I wasn't familiar with this current bill that's being passed, but one of the huge barriers in healthcare is inaccess to information. So
we're going to move on back to the payer and look at this from the innovation point of view, and again from a technology and innovation point of view. Take it away.
Great. So first I'm going to start with, let's go back again in history just for a little bit. And, when you think about how, from a payer perspective, we used to design, we designed it all from our perspective. Everything was looked at as to say, well, how do you manage risk, or what is this program? Or even if we were put something out there, we didn't think about the consumer. We thought about it from how does it end up having a level of control. So I look at the primary sort of innovations, or these things that have really changed and are changing the way we're blanketly thinking. The first I would say is ACOs, so accountable care. Everything that was again looked at is we had our insurance programs, kind of what the payer did, the provider did their thing, an employer might be doing their thing, and nothing was really connecting. And so what accountable care is really looking to do is create that overall connection between the provider and the payer, and to think about that patient and to orient around that patient. So we are changing so many of our processes and programs, and what we're seeing is, we're morphing, the providers, the delivery systems are morphing, and everybody is looking to say, again, what is it from the best interest of that member? You know, how do we keep them engaged? How do we change, you know, their health? How do we look at them longer than were you there for just that visit, but how are we going to help them to actually manage their health? It's creating differences in how we staff, on what the resources, on our clinical teams, on what our customer service does, how we're acting more from an advocate role. It's changing at the provider landscape, but we're all really moving. And what you could hear is the more sophisticated, or those that are like pushing the envelope, the purchasers, you know, like with the healthcare authority, they're 100% all in as well, as to say, how do we serve our role in getting this entire sort of system to work? So to me, it's like, while we have loads to go, you know, that's one of the key innovations. I'm down to 1 minute, so I'll make this really quick the second. The next other item is transparency. You know, we've put out transparency, and everyone says, well, healthcare should be just like buying a car. Well, I'm sorry. You can study up and learn about a car pretty easy, but for you to learn about every single condition gets more complex. So what we rolled out, we've been building on what those transparency tools look like, how to actually make them more consumer-focused, understandable. One of the tools we just recently have gone out is Med Savvy, and that's pharmacy. And so what did we do that was so different? We gave it like grades. Is it an A, B, C, D? We didn't add the level of complexity to things that when we initially used to develop, to say, you know what, they're going to need all this. Well, they don't. They need what's simple. What is there enough to understand? And I can go talk to my doctor. If I have more questions, I can talk to a pharmacist.
So with that, do you have some questions? That's a good example of the kind of technology from a payer perspective. Are there other thoughts you all have around the table or out here that you'd want? Oh, way over here.
Hi there. I'm another provider, so I definitely am very familiar with how difficult it is to extract meaningful information from the medical record. One of the places I think that healthcare clearly struggles, I know Maura alluded to this also, is data. And one of the places I'm curious what your thoughts are, what can the insurance industry do as really the warehousers of enormous amounts of data? So you're at Virginia Mason, I'm at the Polyclinic, our systems don't talk to each other. I would have no idea what happened to one of my patients that was seen there, except when I get in the mail or on a fax machine, a note sent over that's just like a word processing document. But you get the claims data, you get information about a patient anywhere that they touch the healthcare system that you guys pay out. And I'm wondering what kind of innovation you're looking at to take some of that data and use it in more meaningful ways.
So first of all is, you know, again, as you think around the payer side, we're no longer just a bunch of people who came from healthcare. We have from data scientists, from those that are focused on artificial intelligence. We're becoming just as much of a technology company as we are a payer. So that's kind of first and foremost. But one of the areas we're moving towards is bringing out a level of technology that integrates not only from claims data, but that can import EMR data. So can bring it in. It's, as many of you know, EMR data for the most part it's lack of a better way to say it, it's a technology way of putting it on paper, right? It's not interactive. So it's being able to take that data, being able to use like I'll butcher it all, but being able to pull out the words and pull out the conditions and be able to drop it into more of a record. So that record is that individual's, and that stays with them wherever they are. So it goes to some of the questions around what would I take with me to that next provider where it should all be there. So as we see it from a payer side, we're looking at the same thing as that a provider could look at, and more importantly, what that consumer does. So as you have care plans and you have everything that get put in there from a provider, everybody would see it, and we'd all start to really, again, look at it from that consumer. And then hopefully we can break down some of the complexities, some of the barriers, individuals' ability to follow through. It's, well, if my provider said one thing, but I didn't understand what they said, how is it following with them? How can they actually follow through? And then ask whether it's, again, comes back to us on the payer side, whether it's the next provider saying, this is what I was told to do, I'm struggling with it. And I think, again, you know, as more and more, as we start to let providers function at the highest level of their license, it's how do we use nurses differently? How do we use like every area of the delivery system and think about it as maximizing and focusing on the consumer?
Thanks.
I'm down to 0.
Mary.
Great, thank you. And the other thought I had about your question is there is the One Healthport sponsored clinical data repository. So we are looking to, as a state, make sure that there is that availability across the state for that sort of information. My colleague, Dr. Sharisa Fatinos, has been working much more closely than I have on that. But there are efforts underway to make sure there is better transparency and availability, knowing that there are those barriers currently. The innovation that comes to my mind, and it reminds me of how Mara started us with, this is not a sprint, this is rather a marathon. And the innovation I think about is the Consolidated Medical Technologies EDDI system. So I don't know, you providers in the room probably are aware of the EDDI system, which is available in all Washington State emergency departments. It comes with a very rich history in that there was a policy decision made at the Healthcare Authority in the Medicaid program respective to payment for emergency departments. And there was a lot of controversy that was generated from that. And the legislature pretty much said in the budget bill during the recession, you guys have to figure this out or else the state's going to implement this draconian payment policy. And so everybody was motivated to work together, and that sort of created an open window, if you will. So as an innovator, it's important to be sort of looking at those kind of opportunities, those sort of crises that are coming up that help stimulate, all right, we really need a solution for this. The Affordable Care Act, the Affordable Care Act and our development of ACHs was another type of opportunity. But what the EDDI system did and what Consolidated Medical Technologies brought forward in all of the emergency departments in Washington State is the ability for providers to look up controlled substances that are being used by the patients that are presenting to them, regardless of where they got that. So the Department of Health consolidates all of those through the prescription monitoring program, and then that's made available through this technology to all of those providers. So fast forward from the recession to a couple years ago when we had a major pain clinic close that had clinics across the Puget Sound as well as some in Spokane, and we had patients presenting to the emergency departments that were unable to access care in the way that they had been accustomed to. And we then needed to partner quickly with many people in the community, but we included as one of those partners the Consolidated Medical Technologies because they could make available a flag for those patients that had been seen by that clinic. And so we were able as a state to make sure that our emergency departments could quickly identify patients who could be in crisis because of the closure of those clinics. So to me, that was probably the most relevant and powerful technological solution that's kind of in a specific capsule. So also, because as we know, there are many big ideas, right? And it's a very complex and big industry, but sometimes there are just those niches that we need a quick solution for and need innovation around.
So I felt something in the air that says I can't let you ask questions now, answer questions so that we can move on because we're behind. I can feel I just felt the energy. So, Aaron, from a consumer point of view.
Okay, there's a lot going on here, and it's exciting because that really represents a lot of empowerment for patients, but not only patients, caregivers, their family, and other folks who are that make up that support system during a patient experience. In terms of trends that it's gonna sound obvious now, but it's maybe it still does. Fit under the the category of a trend, and that is crowdsourcing of data for research, patient registries. I know Leukemia and Lymphoma Society has promoted a Patient Connect, a network where patients can get together, and what it used to be a listserv, but is now a portal for patients to connect and be able to share in their experience, which has been really powerful. Crowdfunding for research is something that has real potential, and particularly now if you look at, for instance, rare diseases that aren't getting a lot of attention or have a lot of support, now because of the digital tools that are available, people can create something. They can create a movement around something, and so I think it's certainly going to see more of that. With the same sort of technology and resource ability, independent patient advocacy organizations are, I think, going to be more of a force. It used to be that you would align with a major organization like the American Cancer Society or Susan Komen or others to have that sort of outlet for connecting with other patients. Now independent organizations are coming up. People Power is an example from a local here in Mercer Island, Andrew Shore. But then also caregiver support is, I think, trending up as well in terms of providing a real framework for caregivers to unite in ways to share information and commiserate, and because they do in fact need their own support system as well. In fact, we had an example here with Care Brigade, wherever Florence went. She's there in the back, has organized in the same manner. Something I think is really interesting is now also you find organizations who are providing scholarships to patients to go to attend medical meetings and be able to report back. So now you're getting firsthand experience from a patient, talking to other patients, but providing really important content about their disease condition. That I think is pretty interesting. Also, again, with in the same vein of crowdsourcing information, you have patients who are now able to really function in a sort of in a research capacity. And again, I'm thinking of diseases that have less attention, and that they're able to really get on the chase and bring information forward that can then lead to important changes. So, a lot of this is digital, it's social, it's connectivity. It's empowerment, it's information, and it's really giving patients new abilities. And so I'm hoping, because I'm in advocacy, that is something that is turned on the institutions and organizations that are, again, trying to serve their best needs, so that that patient-centeredness really becomes a patient force in terms of effectuating the kinds of changes that they see are relevant.
Thank you. And we still don't have time for questions. So I'll let you go last, so that way you'd have time to think about this and actually have a few minutes of prep.
I think if I think about this question, I think the obvious first answer for me is the EHR, and I think that will continue to change, and we've talked about that here today. It will continue to drive innovation in healthcare as we learn how to manage that data more and leverage that data more effectively. The other big thing I would say sort of unexpectedly for me is just the provider engagement in social media. As I did not, when I graduated from medical school, expect to be like tweeting and things like that. And patients expect that type of, my feeling is that patients expect that kind of interaction. They want to hear on social media from their providers. And it is definitely a way to grow your practice and things like that. And so, there are a million ways, I think, where there are a million examples of how innovation is happening in healthcare, but those are the two that sort of stick out in my mind right now.
Thank you. Ultimately, if you're from an entrepreneurial point of view, if you want to change the world, you have to figure out who your customer is. And the way you can always tell a customer, which is interesting because it seems hard in healthcare, is they actually give you money. Because for a long time in healthcare, we've treated doctors as though they're actually the customer, and actually they're the product. They're the car, not the customer. And as you get to understand that, and then you start saying, what is the need of the person who's writing the checks? Follow the money that way, and I think that begins to help you. And then you'll see, to meet their need, that customer's need, you have to reconnect the Ds, because it won't work otherwise. But I'd say start by following actually who is your customer, and going from there. That would be mine.
Yeah, and the thing I was going to say is I'd echo where that was. The other thing I would say is as you're innovating, you know, the biggest challenge, and I think innovation before used to say, wow, here's a way to get money, right? And we never shrunk the pie. Just somebody else took a different piece of that pie and the pie stayed the same or continued to grow. Everything going forward, the expectation is what you innovate reduces that pie. And that's going to be the biggest element of the push. So whoever it's selling to, wherever that is in sort of that food chain right now, the pie has to get smaller. We're hearing that, and that has to be what that directive is. There's no more of it's just nice to have. It's got to have true outcomes, because in every area we're measuring it, or we're trying to figure out how to measure it and how to drive, you know, to that lower cost. That would be my advice.
I think connecting institutions has always been a good idea. Connecting institutions has always been very difficult to do, and it's happened in smaller ways, but it's hard to keep to sustain that. I would say that if it's something that it can derive real meaningful benefit and is important to from the patient's perspective, organizing patients to push that cohesion and ensure that it sticks could be a mobilizing force. Again, if you can demonstrate that there's real benefit to the patient, that's something that they can get behind. I think because of the receptivity to the patient voice and patient experience, I think sometimes it's that impetus that institutions need to really have the courage to do what they may not necessarily be inclined to do, but can be convinced if they have enough pressure to actually follow through.
So let me move us to, oh, go ahead.
I would also just make a quick plug for gathering the evidence. So it is really important that we are moving towards making sure that what we have innovated and what we are making available is based on good, solid evidence, and that that's part of the consideration as well.
I don't want to be left out. I don't want to also, I want to maybe say something. The moderator says something, and I'm just going to put it maybe a little different way. I hope it's not viewed as contradictory, but with us, it's, you know, we, because I know a lot of the Cambia Health community now, and some of you folks come and talk to me and stuff like that. We don't actually buy a lot of stuff. I mean, obviously the FDA, Food and Drug Administration, or the Centers for Disease Control and Surveillance buy equipment and stuff like that. But when it comes to all that money we spend on Medicare and Medicaid, you know, there's a coverage decision by CMS, but it is the doctors who are driving whether they want to use, whether they want to prescribe your pill, whether they want to use your medical device in their practice. And so what we're trying to do, you know, we want to move from fee to value without telling the doctors how to be doctors, right? That's the challenge that we're facing.
So let me move us to our last section. Oh. From From my perspective, there are three customers. One happens to be the government, because they are the biggest purchasers of healthcare in the world. Second is employers, because they write big checks to payers to transfer it over. And in essence, I think of, and having come from being in the payer side, we're the credit card. And then there's individual consumers, ever more and more and more being stuck. Those are your three customers. That from my perspective.
I would say yeah, and I also try to think about those employees who may not be a patient yet, but are really wanting to have sort of the health and well-being in order to you know, have their value-driven life. So I always think of our customer as being the patient, but now really trying to expand that also to non-patients, people in our community, people who have our coverage. I would say definitely from my perspective, the customer is the patient. And,
when I think about innovation and what I want to do, it all is around moving the needle on the actual experience and quality of healthcare that's received. But I mean, the economics have to make sense. There's no question about that, because that is the behind the scenes driver. But when I think about what gets me excited about innovating, it's about improving the actual quality of healthcare that's being received or delivered.
So with that, let me move this to thinking about trends. And I'm going to tell a story. So I was speaking at a conference not too long ago, and I was talking about an interesting word, which I call context. How do you actually get people to do stuff? Because I totally agree with you, Tim. We have, ultimately, the pie's got to get smaller. You can, and to make the pie smaller, somebody's going to have to get less. I mean, there's going to have to be people around the table other than the customer who should be getting less, which is providers, payers. We should be doing something less. And he was telling me about how he had a patient who had diabetes, and he would not take medication. He would not take insulin, but he was extraordinarily on time for every appointment. He would come every 4 months to see his doctor and then not do anything the doctor said. And so it got down to where they just shot the shit every time he came in because there was no point in getting him to do anything. And what happened was, one night he said, "So what are you doing today?" He said, "Well, I'm going to go out and buy a new fishing rod for my grandson because it's his birthday tomorrow, and we're going fly fishing." At which point the little light went on, and the doctor said to him, "Just so you know, based on your foot exam today, you will never be able to go fly fishing after tomorrow. Your feet are so bad because you can't be in the cold water." He started his insulin that day. He did not give a damn about his health. He cared a great deal about fly fishing with his grandson. One of the things I haven't heard here, and maybe that's where I'm trying to as a trend, I've heard us all talk about data. I've heard us talk about ACOs. I haven't heard hardly anything at all about actually collecting the data that actually drives people to behave the way they do. And smokers already know they shouldn't smoke. People who are overweight, how many of you have a health behavior you don't like the way you do it? How many of you know that it's bad for you? How many of you keep doing it even though you know it's bad for you? So clearly facts do not move people's behavior. So I'd like to suggest that there's a whole other world of data and building contextual relevance to actually how do you do that, and then how do you integrate that back in, which may be a place for entrepreneurial people to start thinking about. So that's a trend I see, is if we're going to be consumer-centric, that's what it's going to have to mean. So other thoughts in terms of what are the future trends to make a difference? It's an open conversation now, including from out here, if you have all thoughts as to what you see as trends. Michael has a trend.
Hi. So I wanted to read a quote from somebody that's pretty experienced in this whole issue of quality. It's from the former editor of the New England Journal of Medicine, Marcia Angel. "It is simply no longer possible to believe much of the clinical research that is published, or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. So my question to you around innovation is, if this Rube Goldberg machine over here is all based on bad research, biased by the pharmaceutical industry, the device industry, perverse financial incentives for physicians, coding games, with the payers, what kind of innovation can we get to improve the quality of care, the actual research-based evidence quality of care? And let me give you 2 examples. Atenolol is commonly prescribed for high blood pressure. The data has been known for 5 years or more that it does not reduce morbidity or mortality of cardiovascular disease, yet doctors keep prescribing it. Okay? Cardiovascular stents and stable angina do not work any better than medical management, but we keep putting them in. Okay? So my question is on innovation. If all this has to be based on quality and making the pie smaller, how do we address this elephant in the room of poor quality research and guidelines?
I love bringing Michael to parties.
Just a simple question. Then we need to be much better at how we conduct research and clinical trials, and rely less and less on drug company and device company and food company funding of research that biases the results, and that's been proven in studies to show that funders change the outcomes of the studies. When you have unbiased funders, it's much different. So I guess part of it is that when Regents is doing studies about something or is deciding whether to cover something or not, they better be darn well sure that what it is actually effective and doesn't have monster side effects that are buried because nobody wants to acknowledge that. So to me, it gets back down to how can we, as payers, providers, patients, get better research, better evidence, so that we have better outcomes for everybody.
Yeah, and
then you, and then over here.
Yeah, and all I would say is, Michael, I mean, you raise a great point that there might be credibility around a great deal of our policies or what's evidence that's out there, but I don't feel like we can blow it all up. We've got to take what's there and what we believe to be proven, and then start going after these areas that we think are waste, that think are inappropriate. But, we've got a system, and I would view it, it's really built a lot on evidence-based medicine. Do we have room to grow? Yeah. I mean, healthcare, it's a science. It's not, it's trial and error. And I think as we grow and we get new information, we'll change some of those policies and go back. And I mean, look for you to say, but I don't think it's all broken, at least from, what the evidence suggests and what we're relying upon. But is there room for improvement? Absolutely.
I'd just like to add that, part of us at the U.S. Department of Health and Human Services is the National Institutes for Health, which is, I think, $33 billion of funding, a lot of which comes into this territory, University of Washington, Oregon Health Sciences University, and other, places in this neighborhood get that funding. And it's has a lot of impact, in the universities. As you transition from the public funding to the private funding, it's the Bayh-Dole Act, right? Am I pronouncing that right? That, the intellectual property. So anyone who has ideas, please bring them forward. Thank you.
Well, and I just had a comment to follow up on your comments, Michael, and that is that in the innovation space, one of the issues, and there's a lot of good research out there, but as you're out talking to investors about your latest, greatest thing, they always ask for clinical validation. What kind of clinical data do you have? And in many cases, we have pretty good data. We have gone out and tested it with people and have data available, but it's always looked down upon or distrusted because we don't have a third-party review. And going through the clinical review process takes forever. And if you're a startup, you don't have forever. So I guess one of the parts of the question is, how do we speed up the process of getting validation of data that is available that may be not derived using the latest, greatest scientific protocols, but which is real and can help get things out into the field more quickly, particularly things that aren't directly impacting somebody's life or death. I'm not talking about a drug trial. We're looking at all sorts of potential implications for a drug trial, but devices or even information types of things that are made available to individuals, and there is evidence that it works, but it's not real evidence because it's not published in the New England Journal of Medicine or some other peer-reviewed publication.
You've actually brought up a very important point, and one of the things I think that Dr. Washington may be able to say is you can do a clinical trial, whatever one's opinion of the sponsor may be, that clinical trial is not the same as what happens when you get into the real world. So that's what we call phase 4, and the message you've just communicated has been heard loud and clear at the Food and Drug Administration. And real world evidence is actually capitalized now, right? We actually say RWE. We've made an acronym out of the term real world evidence. And for those who are interested, look through the FDA's website. I can't give you chapter and verse. I'm always cautious when I talk about the FDA. I'm cautious when I talk about anything because I'm a simple economist, so I don't like to talk about science and stuff like that. But they definitely want to move down the path of using real world evidence to speed up without jeopardizing safety and efficacy approvals. And any intelligent expert input on those deliberations would be most welcome at the FDA.
I think that's a really good question, and I think there's a lot of evidence now that medical knowledge does not keep pace with medical practice, and I think there's also ridiculous amounts of medical knowledge, right? I think if we look at how much you used to have to know in medical school in 1960 compared to what, like you can't know everything at this point, and I think that's why we're here. That's part of why we need the technology people to be involved in this. And I think I went to a really exciting conference last year on artificial intelligence in medicine, and I think that there's so much data that's there that's locked into the medical record in this really stupid way because it is basically a word processing and billing system. And for the people in here who know more about technology than I do as a doctor, that's what we need you to do for us, is figure out how to leverage that information and pull it out in meaningful ways so that patients who are seen, on day 60 of a medication, you realize suddenly that there's many people with problems, like to have that interoperability of systems and to have that ability to pull useful data from pooling the insurance data and the medical record data, I think is going to be how we get this answer. And I think this is where the US is falling behind a little bit because our system is so fragmented, and other countries that have more universal access to patient data are able to get these insights faster. So I think this is, it's a really exciting time, but I also think this is where we need to really pull these two, healthcare and technology need to come together and really figure these out together. So, but I think it's in there. The data's in there. We have tons of medical records out there. So how to get it.
And maybe just to add one quick perspective, and clearly this is a problem broader and more complex than a singular solution, but from a patient advocacy point of view, I do see an opportunity for patient advocacy groups to serve as a watchdog, putting pressure on players in the system to ensure that what they're getting is what they know they should be getting versus what is presented to them.
I just want to second what you have said, and I also want to say I'm not as pessimistic about the current state of our medical evidence as the editor of the New England Journal is. But I certainly believe we have a lot of opportunities to improve upon it. I think, I've worked on several systematic reviews and meta-analyses where you pool data from multiple studies to try and have more powerful commentary on the results. And I think those types of studies are increasingly necessary. I can also say from having worked on those studies, it can be frustrating because there is a lack of, you find that it's hard to make recommendations because there aren't, enough trials to create meaningful comments, but then those studies can drive the available research. The other thing that I was going to say about creating devices, I think post-market surveillance is super important. So you get a device to market, you've proven that it's safe and effective. I think one of the big problems in my experience has been, what happens 5 years from now when there are issues. And the FDA is has created incredible repositories for reporting post-market surveillance issues, and that should be routinely done, in my opinion, for devices that are new to market.
So let me add a thought. We only have a few minutes left, because I love your comment about we need to shrink the pie. If you're going to shrink the pie, the first question you ask is what makes up the pie? What's in it? How are you going to shrink the pie? And we know that actually medical care itself only represents 10% of what's going to generate outcomes in terms of people's health. So we're talking about creating huge amounts of data to make the 10% work better, usually at a higher cost because we're talking about very expensive stuff. So what kind of data are we collecting to actually change prevalence of disease and outcome? And I would suggest that we've kind of already gone down a path that's the medical industrial complex path to begin with. And so we're looking for solutions within that path itself. And I think that's worth thinking if you're looking at future trends. One of the things, we spend twice as much money as any other country in the world per capita, right? And we have Slovenian type of outcomes to go with it. But what other countries spend a huge amount of money on, and you should like this, is public health. Oh my God, government spends all kinds of money putting, the solution to an obesity problem is a sidewalk. It is not a monitoring device, it's a sidewalk or a tree to walk under when you're on the sidewalk. So I think as you look towards innovation, you may need to look beyond, if you're really wanting to do, because I agree with you, that is the right question to ask, is how do we shrink the pie? The solutions you're going to be looking for are not necessarily in yet more medical devices and more better research on just that path. It's just a question back there, and then.
As a product guy, the young lady over there, she was talking about the medical information that's out there that has data, and then the fellow talking about the research, that research being suspect. As a product guy, our devices are starting to span the world, and the data that we're collecting spans across healthcare systems. And so we're going to find out real fast in the next 5-10 years, as we start looking at the data across countries, we're going to see who the cheaters are, who the effective uses are. So I think from policy, from payer, start looking at that being the technological solution, right? And we're going to catch the areas that are effective or not effective, and start to tweak out people doing things for personal gain rather than for public health.
So I just wanted to, you gave a good introduction to what will be my closing remark. So we're very focused now on social determinants of health, and we've got a big research program in the department on social determinants of health. And as we say, the diabetic patient, if he doesn't know what his diet should be or can't afford his diet, the healthcare in the world is not going to do him any good. If a mother has a kid with asthma, the doctor can't prescribe move to a new apartment, if it's the environment which is causing the problem. We face statutory barriers in actually implementing any social determinant of health as a factor into risk adjustment or anything like that. Medicaid, you folks are limited, right? So we need statutory reform there. Also, some of the human services programs aren't in our department. Many of them are, but supplemental nutrition aid to SNAP, we used to call it food stamps. That's U.S. Department of Agriculture. WIC, Women and Infant Children Formula, that's Department of Agriculture. The president has proposed to bring them into our department and renaming our department Department of Health and Welfare, so to get the whole complex together. That's one step in the right direction. My last remark is we have a draft strategy on interoperability, strategy on reducing regulatory and administrative burden relating to the use of health IT and electronic health records, which we published in November. Comment period closes at 11:59 p.m. Eastern Standard Time, January 28th. So if you haven't read it and submitted your comment yet, Google it and submit your comment. Thank you.
So since we only have 1 minute, the one thing I would throw at everyone is to start thinking differently about behavioral health. And, many are looking at it and realizing how that is impacting not only health, but the healthcare system, but family dynamics. And that's an area. So we're just beginning to scratch the surface. We know there are many gaps, but I would say think about behavioral health, think about resiliency, think about how we're going to help move that paradigm and what the implications are on overall costs and productivity in our healthcare and in our population.